Okay. Good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo ng mundo naroon. Welcome to our 226th episode of the Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community at sa lahat po ng very first time na makakasama po natin for today. Sana po marami po kayong matutunan sa ating topic. Very, very interesting, very exciting din po topic that we have been I think very timely din, no? What do you think, Nina, in terms of that timeliness of the topic given it's Valentine's Day? We are looking at what we want to call infertility po, no? So it's a condition affecting millions globally, presenting a significant challenge po para po sa mga couples aspiring to parenthood. So we want to be able to empower you, give you some educational resources din po and equip you with the knowledge necessary to navigate the complexities of infertility and offer informed support, especially for those who are affected. We are very, very fortunate to have a STEAM panel po of experience and very expert po, no, OBGYN specialist pagdating po sa infertility. We'll be talking about multifaceted nature of infertility, what are its causes, including both the male and the female factor. So hindi lang po ito sa isang sex lang po kumbaga na ma-attribute. We'll also be discussing physiological processes involving reproduction, how disruptions at various stages can lead to infertility. Also, how do you diagnose it? What are the diagnostic methods that are used to evaluate infertility? A hormonal assay po ba? Semen analysis? Are there imaging techniques like hysterosalpingography? Are those things really helpful? How do you move on to interpreting these diagnostic tools? And how do you better understand po the patient workups and contributing to informed decision making? We hope to be able to equip you and help you gain the knowledge and skills so that you'll be able to, given that you're mostly frontline healthcare workers, how do we provide compassionate and evidence-based care to individuals and couples facing infertility challenges? This is the Health Updates webinar series. I'm Dr. Raymond Francis Sarmiento, your host. And today, again, we're very fortunate. We have Nina Liu, who will be my co-host for today. Nina, how are you?
Hello, good afternoon, Dr. Raymond. I'm very happy to be back and spending part of our Valentine's Day with everyone dito sa Health Updates community. Maraming salamat po sa lahat for taking time out of your Friday to join us in this regular lunch date. And of course, it's very exciting to welcome you all to our 226th webinar. And to all those who are watching live on Zoom and on live streaming sa ating TVUP YouTube channel at sa UP System Facebook page, TVUP Facebook page, and of course, TVUP Signal TV Channel 101. Like Dr. Raymond said, more or less very timely ang ating topic dahil araw ng pagmamahalan at alam naman natin na starting a family starts from, love. And so let's not mistake the inability to do that with a lack of love. Sadyang sometimes it's really a health concern that should be talked about, and we will be understanding more in this episode. Now, our main presenter for today is Dr. Gia C. Pastorfide, who is a clinical associate professor from the Division of Reproductive Endocrinology and Infertility of the UP-PGH, Department of Obstetrics and Gynecology. Our reactor is Dr. Gizelle Samonte-Alfonso, who also holds the position of Medical Specialist 2 as a Gynecologic Oncologist from the Mariano Marcos Memorial Hospital and Medical Center in Ilocos Norte. Now we will continue to take a closer look at existing and emerging health problems in the Philippines and the rest of the world, pero hindi na natin patatagalin pa. So to jump to our discussion, we will be watching our Persons on the Street video. Dr. Raymond, do you want to take this away?
Thank you, Nina. So we'll go ahead with the pots and the questions that we pose to our interviewees po are as follows. We wanted to ask, mayroon po ba kayong kakilala na hindi kaagad magka-baby? Ano po ang kanilang ginawa? Ano po sa tingin ninyo ang pwedeng gawin o pwedeng ihanda upang makabuo ng baby at ano po sa palagay ninyo ang rason kung bakit nahihirapan o hindi kaagad nagkakaroon ng anak yung mga gusto pong nagbabalak na magkaanak at kailan po ba dapat magpakonsulta sa doktor pag nahihirapan mag-conceive ang mga prospective po ng mga parents. So we have our pots here just to give us an inkling po no what is the baseline awareness po of our interviewees. So please go ahead, TVUP.
Actually, yes. Myself.
Yes, I know a lot of couples who had a hard time or are having a hard time conceiving. An example of which is my parents.
Yes. Actually, I was diagnosed with PCOS 2016. So, I'm actually married for 12 years and wala pa po kaming baby. So we're trying to have one, but unfortunately hindi po kami nabigyan pa. Because of that, dahil alam kong may PCOS ako, na foresee na namin ng partner ko, ng boyfriend ko at that time, na baka maging struggle yung pagkakaroon ng baby.
So what they did, from what I heard, well, ipa-check up sila to multiple doctors, and also, they're from Mindanao, so they went to doctors from Luzon, Mindanao. They also tried to go to the fertility statue when it was here in the Philippines, and I also heard that my mom had lots of hilot. Yeah, and actually they believe that the hilot helped for her to bear a child.
Unfortunately, it took 2 years bago ako nabuntis. So, yes, isa kami sa nag-struggle talaga na makabuo ng baby. I believe na one of the most impact bakit po wala pang baby, it's because my husband is a CKD patient. So, yun po yung isang impact.
Para makabuo ng baby, need to be completely well, like physically, most importantly, mentally as well, psychologically.
Napacheck na po ako sa OB, and then she told me that may PCOS po, and so we're trying to mawala yung certain na diagnosis na binigay ng OB. I think isang factor, syempre yung condition ko, because may PCOS ako, so mas mahirap yung pag-conceive kasi irregular din yung menstruation ko, and ayun, so mas mahirap. Like kapag regular yung menstruation mo, mas madaling i-determine yung fertility window na sinasabi. So I think yun yung isa sa factor but nahirapan talaga kami is because of my condition. Kailangan po not just me na pwedeng pumunta sa OB, but he needs also to work up po sa OB ko para ma-check din po kung bakit, or baka hindi na pwede, it's because of his condition as well. Sa akin, tapos may mga prescribed na gamot and vitamins, supplements para maayos yung hormones. Ayun, fortunately, nagkaroon naman kami by 20, parang we started yung work up ng November 2021, and then around Feb or March, ayun, nabuntis na ako. If you really wanted to have a baby and you think yung sa first try hindi po, yes, I believe na our doctors will guide us. Para malaman natin kung they will guide us kung ano bang kailangan i-work up sa inyo to have and to conceive one.
Okay, thank you so much, TVUP. Very important po, no, that we gain a better sense of their, maybe their ano po, no, their state po emotionally, and the journey
Correct.
that that they went through, the decisions that they had to come up with, yung kanilang mga doubts and fears, very very important. Really, this is all about just making sure that we're able to provide the best information for that they're able to go ahead with informed decisions po, no? Before we start off with our webinar proper, just wanted to remind everyone that all those who are asking certificates of attendance, they have already been sent out. We've also responded to those who have asked clarificatory inquiries po, no? So those who have watched at least 50% of the webinar duration will be eligible to receive certificates of attendance. For webinar today, we'll be having a standard panel discussion format, and we have all our speakers presenting their talks, and that will be followed by a standard Q&A session. We'll get the ball rolling, and then Nina will introduce our main speaker for today.
Thank you very much, Dr. Raymond. Like I mentioned earlier, our speaker today is a clinical associate professor from the Division of Reproductive Endocrinology and Infertility of the UP-PGH, Department of Obstetrics and Gynecology. Everyone, please join me in welcoming Dr. Gia C. Pastorfide.
Hi, good afternoon, everyone. Thank you, UP, for inviting on infertility, and just like the Raymond time, timely time. What would be Valentine, and we're talking about, couple trying to conceive, create a family. So, am I pinned already, Nina?
Yes, Doc. Yes, we see you.
Yes, go ahead. Yes.
Great. So I divided my lecture into 4 parts. First, let's define first infertility. And then we go to the main topic of the lecture, which is treatment options. What can we do for patients who are having infertility? And of course, this is especially used for generalists. No? What can you advise patients to optimize their fertility? And just a little, common misconceptions, fun facts that you can have about fertility. So let me share my slides. Again, I'm Dr. Gia Pastorfide. First of all, what is infertility? It's the failure to achieve a pregnancy after 12 or of regular unprotected intercourse. Are some keywords in this definition. First of all, it's 12 months without using protection. There's a caveat to that though. Say, for example, if the patient is older than 35 years old, or maybe she has other medical conditions, like what I heard from the video earlier, PCOS or endometriosis, male factor. If you aren't able to conceive within 6 months, you will already fall under the definition of infertility. Now, primary infertility occurs when a couple has never conceived, and secondary infertility is defined as the failure to conceive following a previous pregnancy. And this pregnancy doesn't even have to be a live birth. If it was a miscarriage or an ectopic pregnancy, we will already define them as secondary infertility. Now, there are many causes of infertility. For the female, these are the most common causes that we have, like, as again mentioned in the video earlier, you have ovulation problems, and most common would be PCOS or polycystic ovarian syndrome. Next would be endometriosis. Others would be uterine factors, like say, for example, the patient has a myoma, or another common one is age, because when patients get older, they tend to have a poorer egg quality. And lastly, of course, if there's blocked fallopian tubes, you cannot get pregnant naturally. So that's a common cause of female infertility too. As for the male, we have sperm problems. So they can have either lower absent sperm, poor sperm motility, or poor sperm quality, meaning the appearance of the sperm is abnormal. And just like for the female also, you can have male tubal blockage. So obstruction can also be a factor of infertility for men. Now, unexplained infertility occurs when after workup of both the male and the female, all the workup is normal, but they still have problem in conceiving. And this is actually a very difficult subset of patients to treat. So let's go to the meat of our lecture now. What are the treatment options for infertility? I've arranged these according to the most conservative, which is timed intercourse, to the most invasive, but it has the highest chance of success, which is IVF. So we have ovulation induction, follicle monitoring, and timed intercourse. Another would be artificial insemination, and lastly, we will tackle IVF. So let's go through these one by one. No? So first of all, with ovulation induction, the patient comes in day 2 or day 3 of their menses, and then they will be given medications, either in an oral or injected form, so that the ovary will be producing follicles. And over this time, the patient will also be monitored by ultrasound to see the development of a follicle. So this is what we want to happen. No? This is the goal. We want to have a good size follicle developing in the ovary. This means the patient is in her fertile period. No? And when she's ovulating ready, the couple will be advised to do a timed intercourse because that's the time when she's fertile. And then after which you do a pregnancy test in 2 weeks' time. Now, there are several prerequisites before you advise patients to do this kind of management. First of all, she should be ovulating. She should be producing a good quality egg. Second, you have to establish that the tubes are not blocked, so they should be patent. And lastly, there should be an adequate number of rapidly swimming, good-looking sperm. So you cannot offer this kind of treatment with patients with oligo or azoospermia, meaning there's very poor count of the sperm. Next treatment that we have is artificial insemination. Here, we see the patient again, day 2, day 3 of their menses, no? And then we will be prescribing the patients either a combination of oral and injected medication again to make the ovary produce the follicles. So just like I mentioned earlier with the timed intercourse, ultrasound monitoring will be done throughout the duration of the treatment to see if a follicle will be developing. And when their follicle reaches a good enough size, and when we deem that the patient is in her fertile period, we schedule for the insemination. After insemination, we do a pregnancy test in 2 weeks' time. So this is the actual process of artificial insemination. First, we get the semen sample from the husband. Usually, we collect this by masturbation. The sperm will be processed, and all the non-motile dead sperm will be removed from the sample, all the debris and um, factors that you don't want from the sperm. We only want to have the good, actively moving motile sperm, and this is the one that we will directly inseminate in the uterus. So here you can see the catheter. You can see the catheter going through the vagina, through the cervix, and directly inside the uterus. Basically, the goal of an artificial insemination is a bit closer. So it's still natural in the sense that the sperm still needs to look for the egg, needs to penetrate the egg, needs to fertilize the egg to create the embryo. So there are prerequisites to this kind of treatment. First of all, the woman should be producing good quality egg. She should be ovulating. She should be responding to your ovulatory drugs. Second, at least one of the fallopian tubes is patent or open. And usually we would advise patients to have at least 10 million motile sperm inseminated in this form of treatment. If the sperm isn't adequate, maybe an IVF with ICSI is a better choice for the patient. Now, the chances of getting pregnant with this kind of treatment is not very high because it's almost a conservative way of trying to get pregnant. So we would say usually around 10 to 12% per cycle. And now we go to IVF or in vitro fertilization. Here, the patient again is given medication. So we inject daily medications to the patient so the ovary produces many follicles. So the ultrasound will be done serially during the treatment to monitor the growth of the follicles in the ovary. Now, when the follicles reach a good enough size, maybe 1.8 to 2 cms, which is roughly the size of a grape, there will be a trigger for the egg harvest to be scheduled. So oocyte retrieval, or sometimes we call ovum pickup, is when we collect the eggs already from the patient. When we have the eggs already, it will be brought into the laboratory for the sperm to be inseminated in the egg. So when we have the embryo ready, we do the embryo transfer, and after 2 weeks, we do the pregnancy test. Let's go to the different steps of the IVF. First of all, this is the egg retrieval. Now, the egg retrieval is done as an outpatient procedure, and you can see here it's under ultrasound guidance. So the goal is to aspirate the eggs from the follicle. So attached to the ultrasound probe is a long needle, which we direct towards the ovary. Now, this needle punctures the ovary and punctures each follicle to aspirate its contents to harvest the egg. So once the follicular fluid is aspirated from the microscope to see if the follicle contained an egg. So this is another diagrammatic representation, no? And this is what we see when we do the actual egg retrieval. So you see the needle inside the follicle aspirating its contents. The follicle is collapsing because the follicular fluid is being aspirated, suctioned out. So one follicle is already done, and you see the needle advancing towards the second and puncturing the second follicle. And you can see the second follicle collapsing again because the follicular fluid is being aspirated. Now, all the follicles in both ovaries will be aspirated. And this is what the eggs look like. So the eggs, we cannot see by the naked eye. These are microscopic, and that's what they look like under the microscope in the laboratory. Now, once we have the eggs, they can be fertilized already. So the egg and sperm are combined in the laboratory, usually by ICSI or intracytoplasmic sperm injection. So here, one sperm is injected into each egg. And then this is what you want to see, no? After the insemination, the embryo should be developing nicely. So you can see in day 1, it's a 2-cell embryo. In day 2, it's already a 4-cell embryo. Day 3, it can be an 8 to 10-cell embryo. So we would grade this a grade 1 embryo because you can see that the cells are dividing uniformly and there isn't much fragmentation present in the embryo. And once you have the embryo already, you can do the embryo transfer. So the embryo is directly injected inside the uterus under ultrasound guidance. So you can see the catheter, the embryo is placed inside the catheter, and this we direct under ultrasound guidance through the vagina, through the cervix, and directly inside the uterus. So we do this under ultrasound so as to put the embryo in the point of maximal implantation. So that's near the fundal portion of the uterus. And then we wait 2 weeks for the pregnancy test. So the prerequisites for an IVF is that there should be a minimum number of developing follicles. Say, for example, when you stimulate the patient and no follicles grow, then that means you cannot harvest any eggs. Second, in this kind of treatment, we do not need the fallopian tubes anymore. In fact, we circumvent the use of the fallopian tubes because you're directly collecting the eggs already from the ovary and it's being fertilized in the laboratory. Lastly, there should be a minimum number of good-looking sperm, not like 10 million motile sperm like an artificial insemination, just enough to be able to inseminate the eggs that we get. So the chance of getting pregnant with an IVF is directly correlated with the age of the patient. And this next graph shows you the chance of getting pregnant with IVF. And as you can see, no, the chance of success is really dependent on the age of the female. So much so, if you are less than 35 years old, getting pregnant from IVF would give you a success rate of 50 to 60%. But as you reach an older age, and in fact, if you are above 40 already, it's more than half the success rate already, around 20%. And if you are 42 years old and above, less than 10% already. This graph is also shows also the success rate of IVF. This was taken from the CDC, no? In the US, they allow third-party IVF, meaning they allow donor eggs or donor sperm. So in this case, the orange line is showing IVF done with patients who are using their own eggs. So you can see when the patient is 35 years old and below, the chance of success, 35 years old and above, the chance of success of IVF starts to decrease already. But from the blue line, you can see that it is relatively stable. This blue line shows the success of IVF with patients who are using donor eggs. If you are using donor eggs, more or less, you would be getting eggs from younger females, no, not older females. And you can see, even though the patient is above 43 years old, their chance of conceiving from IVF is still almost the same as those who are young, as like young patients. Now, long before, IVF used to be very taboo, no? In fact, we used to have patients who didn't want other people knowing that they were doing that form of treatment. But I believe because of the age of social media and, a lot of celebrities endorsing, IVF is gaining popularity, so much so that a lot of patients and their children, celebrities have their children from IVF, and that's why it's gaining more acceptance already worldwide. So we see here Sarah Jessica Parker, Courtney Cox. Locally, we have Vicky Bello, Corina and Mar Rojas, Alice Dixon, Divine Lee, the Obamas, and Joel Cruz. They all had their children from IVF, and they share about this in their social media accounts. Okay, so as generalists how can we advise patients to try to optimize their fertility? So of course we have to take into account the male and the female, no? So to advise our patients would be to eat well. Eating well promotes better glucose metabolism, so it will help with the ovulation. So we would advise patients to take foods that are higher in monosaturated to trans fat ratio. So these monosaturated fats are found in plant foods like nuts, avocados, the healthy oils. Trans fats are the ones that you want to avoid, such as those in junk food, no, yung mga things that are actually very yummy. So yung mga donuts, cookies, muffins, cakes, you want to avoid that. We want to advise patients to take a higher percentage of protein from vegetable rather than animal sources. So we also advise them to take low glycemic index carbohydrates. So these low GI foods would cause lower spikes in the blood sugar, and they are found in food like soy products, beans, fruits, uh, grains, porridge, and lentils. Now, we also tell patients to think before drinking because moderate and heavy drinkers tend to take a longer time to achieve pregnancy. Next, we tell patients to also watch their weight because and it's not only those who are too heavy. In fact, those who are underweight would also have an increased problem with conceiving because they have problems with their ovulation. And studies show also that smoking is a deterrent to conceiving. So in fact, those who smoke more than 10 sticks a day, that can also be detrimental to trying to conceive. When you smoke, it can cause adverse tubal or cervical changes. It can cause damage to the eggs of the woman, and in fact, increase the incidence of miscarriage and ectopic pregnancies. And of course, we also have to check the sexual health of the patient because say, for example, we have sexually transmitted infections. These can cause problems with the fallopian tubes if left untreated. And, this can increase the risk of ectopic pregnancy. So checking your sexual health also means keeping track of your menses. So if you're having irregular cycles, such as those patients with PCOS, more likely they are not ovulating. Now, for the male partner, what can you do about it? Just like for the female partner, we also advise them to eat well. So we want them to eat healthy. So we advise for zinc-rich foods that's found in oyster or beef, seafood, folate-rich food like you find in the leafy greens, and vitamin C supplementation. Just like for the woman, we try to tell them to limit their alcohol intake. Think before drinking. Heavy alcohol use is also correlated with abnormalities in the sperm function. So actually, in fact, most of the advice that we give for the female is applicable to the male. We also tell them to watch their weight because being overweight can lead to lower sperm production. We tell them to avoid smoking because smoking can decrease the count, the quality, and motility of the sperm. It can lower their libido and increase the chance of impotence. So, in fact, the nicotine in the cigarette can cause harm in the sperm DNA. We would advise also the couple to avoid lubricants because there's some lubricants that can actually interfere with the sperm motility. So it will make it more difficult for them to conceive. And some of these lubricants can also contain chemicals that can kill the sperm. And lastly, we tell the patients to minimize exposure to heat. So a man's testicles should always usually be 1 or 2 degrees cooler than the rest of his body to prevent problems with the sperm production. So we would advise the male partner to avoid prolonged exposure to direct heat, such as, sauna or hot bath. And we would tell them to avoid wearing tight underwear. Okay, lastly, let's just deal with some common misconceptions with people who are trying to get pregnant. So first of all, don't wait to take supplements. Don't wait until you're pregnant to start taking them. In fact, even before getting pregnant, you should already be having a folic acid supplementation. Now, don't wait too long also before seeing a doctor. In the video presented earlier, one couple mentioned that they were married, I think, more than a decade already. So it will be harder to treat patients if they prolong the time before seeking consult with the infertility specialist. So the golden period to try to conceive is 6 months if you're above 35 years old, or if you have other problems, or 1 year if there are no problems with the male and female, and if the female is less than 35 years old. Second, don't ignore any health issues. Again, with the video presented earlier, I think the husband had CKD, chronic kidney disease. And any health problem can also affect the chance of fertility, increase the chance of infertility. So hypertension, diabetes, these can all contribute also to infertility. And lastly, fun fact also, because some patients ask, what kind of sexual position, but in fact, coital position does not affect the likelihood of conception. So this is my presentation. Thank you for your kind attention, and I welcome your questions later in the Q&A.
All right, thank you so much, Dr. Gia Pastorfide. Napagaling. Ang ganda ng presentation. I think that's probably the first or second time that we've had a presenter use Prezi po, no, for our presentation. What did you think of it, Nina?
Very thorough, but also very clear yung presentation ni Dr. Pastorfide, which I think is appreciated by many because ang daming present ni Doc na methods to go about infertility, and hindi daunting, hindi nakakatakot yung way ng pag-explain ng information ni Dr. Pastorfide, which is very encouraging. So maraming salamat po.
Thank you so much. So, okay. So, sa mga kalalakihan po, no, wag po kayo masyadong magsosona or mga ganun po yung aking take away from that one. We just wanted to greet po muna those who are watching us locally from the Bicol Region General Hospital and Geriatric Medical Center in Cabusao, Camarines Sur, Antipolo City Hospital System in Antipolo, Rizal. Home Healthcare Placements Incorporated in Bacolor, Pampanga, University of the Philippines, Mindanao, Davao City, Davao del Sur. Obviously, Mariano Marcos Memorial Hospital and Medical Center, Batak, Ilocos Norte, where one of our speakers is located, and Zamboanga City Medical Center in Zamboanga del Sur. In the chat, we are seeing those and obviously, Happy Valentine's Day. Nina, Happy Valentine's Day po sa
Happy
inyong
Valentine's,
lahat.
everybody.
From Hospital ng Binyan, thank you so much. From First Gen Corporation, maraming salamat po. University of Rizal System Health Services Unit. From University of Santo Tomas, thank you so much. Quirino Memorial Medical Center, maraming salamat po. St. Anthony Mother and Child Hospital in Cebu, the City Health Office of Antipolo. Montalban Rizal also, Marilao Bulacan, San Jose Occidental Mindoro, MOP-MG. Thank you so much everyone. And from Bataan po, Quezon City and Quezon Province. Internationally, we are also being viewed by our colleagues and friends, avid viewers from Nam Canto University Hospital in Canto City in Vietnam. Ryan Hall Shanex Incorporated in Bridgewater, Canada, and Chuan Hospital in Taipei City, Taiwan, as well as University of Hail in Hail Kingdom of Saudi Arabia. Okay, Our next speaker naman po, and then thank you again to Dr. Pastorfide. She will be reacting po to the talk of Dr. Pastorfide. But before that, we want to remind everyone, if you have any questions, please put them in the Q&A session. We'll be choosing those, especially those that have been upvoted, encouraging everyone to start typing in your questions in the Zoom Q&A, as well as the comment section of the UP System or TVUP Facebook pages, as well as the TVUP YouTube channel. Okay, our reactor today holds the position of medical specialist 2. She is a trained gynecologic oncologist from Mariano Marcos Hospital, Mariano Marcos Memorial Hospital and Medical Center in Batac City, Ilocos Norte. We are very, very privileged to have her, Dr. Gizelle Samonte-Alfonso.
Hello, sir. Good afternoon,
Yes, good afternoon.
everyone. Can you hear me, sir?
Yes, loud and clear. Go ahead, Dr.
Okay, sir. Okay, so good afternoon, everyone again. I'm Dr. Gizelle, Dr. Gia's OB-GYN residency batchmate. So first of all, I would like to thank Gia for choosing me to be the reactor for today's webinar. This gives me an opportunity to talk about our infertility journey and to be able to give hope and to be an inspiration to other couples who are struggling to conceive. No? So to give you a backstory, we got married in 2016. I was 33 at that time and my husband was 35. We didn't want to have a baby at that time yet since I just finished my fellowship training. He just finished his residency training. And then we wanted to establish our practice in the province. And then, of course, like any other couple, diba, you want to be with each other muna, no? So after 2 years, we tried to conceive using natural methods, no? Just like what Dr. Gia mentioned earlier, timed intercourse. But sadly, it didn't work. So while my husband was in fellowship training, we consulted an infertility specialist, and we were advised to undergo some tests. And then after which, since my fallopian tubes were patent, his semen analysis was normal, no? We were advised to undergo IUI first before proceeding with IVF because we wanted IVF first, pero sabi niya, IUI first. So after 2 unsuccessful IUI attempts, that's when we decided to go for IVF. So that was in 2020, but the pandemic hit. So IVF was not allowed at that time. So in October 2021, that's when our IVF journey started. We consulted Dr. Pastorfide, underwent what she discussed earlier. We had 4 day 3 embryos, and we did a fresh transfer of 2 embryos. Unfortunately, the embryos didn't implant, and we had a negative pregnancy test. So it was one of the most painful experiences we had to endure. And it took us quite a while, 9 months. That was in July 2022 to give it another try. So during that second cycle, on day 8 of stimulation, my husband then developed or tested positive for COVID. So we had to abandon that IVF cycle. So parang second failed na yon. So it was again a very tough and devastating experience for us. So at that time, parang we wanted to give up and just accept that conceiving is not for us. But after 10 months of thinking and reflecting, that was in May 2023, and kumbaga parang, sige, let's try. But sige, ituloy na natin to kasi baka magsisi tayo later on. So I had my AMH levels tested again, and it showed dwindling levels, no? So at that time, we decided to have another cycle of IVF. So that after the stimulation and harvest, we only had 2 embryos, and then both were transferred fresh. So at that time, dahil natuto na kami sa first IVF transfer namin, hindi na kami nag-expect. So we were not expecting positive results anymore kasi the odds were not like being in our favor. And lo and behold, we had a positive pregnancy test, and that was probably one of the best, or that was the best good news that we have ever received. So on January 20, 2024, we delivered a baby boy by cesarean section, and last January 20, 2025, we already celebrated our baby's first birthday. And Dr. Gia also came to celebrate his first birthday with us. Yun lang po. And then I'll share some pictures just to inspire infertile couples na, di ba sabi ni Dr. Gia kanina, the chance of success at 40 years old is approximately 20%. So I think I can attest na may pag-asa even at the age of 40 and beyond. Can I share my slide, sir?
Yes, go ahead, Dr. Gizelle.
Okay. Can you see
It's
the...
coming up. Oh, okay, there we go. Can you go
Yeah.
to... Okay, there we go. Okay.
Okay. So, ayan po. So, okay. So, more of pictures na lang po ito, no? Of sharing our victory. Okay, so on June 5, 2023, that was our first ultrasound with Dr. Gia, no? Fetal viability was confirmed, and the baby had heartbeat detected on ultrasound. Okay, and then we delivered a baby boy on January 20, 2024. He was 38 weeks and 3,433 grams. Okay, this is a picture of our baby. Okay, this is our picture first day postpartum. So Gia was with us all the way from start to finish. And this is his picture now. He's already 1 year old. And then they came to Ilocos last January 20 to celebrate his birthday and baptism. And I think this is the last picture. Finally, our family picture. Okay, so that's it, sir. Thank you very much. I hope I have inspired couples who are struggling to conceive. Thank you.
Very helpful, Dr. Giselle. I think these types of stories po, no, very inspirational. Our audience really likes these stories po, no? And very, very welcome. And we're very grateful that you're able to be open and was able to share this po, no? We'll call in Dr. Pastorfide for our questions. Do you have any questions, Nina, on your end? I may have maybe 3, and then but go ahead with the first question.
Right. We have some questions that have already come in po, pero I wanted to kickstart that discussion by asking, siguro for our friends po in the regions, how accessible are these alternative methods po to conceiving, considering I know in the metro more or less mas common na po siya, pero for those who across the Philippines are having trouble.
You're asking how many Gia Pastorfides are there in the Philippines?
Indirectly, Doc. Opo, yes.
In terms of IVF, we only have 8 IVF centers in the Philippines. But we have all the south in Davao, and we have in Cebu. So but I don't advise to do a stepwise approach. Them in the like what Dr. Gizelle went through. No, she had several cycles of IUI, and most centers, even some hospitals can do IUI as long as you have infertility specialist in the area. Will know how to do an intrauterine insemination.
Okay, sige po. Doc Raymond, how about our other questions from our viewers?
Okay, question. I think this one po, no, just inquisitive mind. For each IVF cycle, there will be embryos po that may not I think unused or something para. So what happens to those I don't know, eggs or embryos? I'm not sure if that's correct. And then what are the options for those, Dr. Gia?
When you do IVF, first of all, you collect eggs from the woman. So when you fertilize them, when the eggs and the sperm are combined, that's what you call the embryo already. Now, if a patient gets a lot of eggs, meaning a higher potential to produce a number of embryos. Now, say for example, the patient is very lucky. They did the first transfer and was able to get pregnant. So siguro, maybe let's peg it at siguro 10 embryos. And then we we transferred one embryo and then she got pregnant. So basically, they have 9 remaining embryos, correct? Those 9 remaining embryos are frozen in laboratory and it can be used in subsequent pregnancies. So advantage of doing IVF, especially for old patients, is that you have those available young embryos at a later age. Do you understand me? Kasi
Yes.
that graph that I showed earlier about the one when they use IVF using their own eggs as opposed to them using younger donor eggs. So you more likely will have a successful pregnancy because you have these younger embryos available, even though technically, kunwari, above 40 ka na, but you have 35-year-old embryos. So that would be a better chance for you to get pregnant.
Okay. Nina, anything else on your end? I have maybe a couple more.
I think she's on mute.
Okay. Oh, sorry. Yeah. Nina, questions on your end? No questions? I'll take this opportunity. What ano po for I'm not sure if Dr. Gizelle participated in these, but are there like support groups for couples undergoing IVF, maybe groups that you're able to share those types of stories? Is that something that was available to you, or did you participate in that kind of support group, Dr. Gizelle?
Actually, sir, I'm not familiar with any support group. Parang wala naman akong nasalihan na support group. But, well, siguro, sir, I'm lucky because I have several, how many, our infertility specialist batchmates who are very supportive. So siguro sila na yung nag-serve as support group ko na, yes, okay, go. Alam mo yun, na don't lose hope. Yun. But kung yung support group, sir, I didn't join any.
Joined it. Okay.
Yeah.
Dr. Gia, anything that you might probably heard?
Actually, Dr. Raymond, there are different support groups. Usually, they have in Facebook. So
Okay.
there's a support group of patients doing IVF already. But even before IVF, infertility lang mismo, there are support groups with that also. So I guess they just need to search and for the groups and join.
All right. Okay. And then finally, I think the important question, is this covered by insurance? Well, how much does it typically cost, or any like the finances around it, Dr. Gia? That's I think I've received like 4 questions about it. Yeah.
Yeah, it's a very common question. Unfortunately, infertility isn't subsidized in our country. So it's not covered by HMO or insurance. Not like other countries where I did my training. In fact, if you're a citizen of that country, you are entitled to free IVF cycles, 3 of them. So very lucky other countries. Sa atin, it's purely out of the pocket. It can go in the range of around 300,000 to 500,000.
Okay. So hopefully that clears up, especially the details. Thank you so much to our speakers. Thank you, Dr. Gia and Dr. Gizelle, our OBGYN specialist po, no? Right now, we will be showing on the screen our evaluation poll. It's Likert, a 4-point Likert scale. It's 5 statements. We encourage everyone here, especially in the Zoom, to answer this evaluation poll po, no? Really gaining how did you think of the webinar topic, and then how do you think of our speakers po, no? I'll read through them. We won't be closing this until the end of the webinar, and then as we move on to the closing part of our webinar po, no? So the number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Again, we will not be closing this until the end of the webinar. For next week, what do we have for next week, Nina?
So for next week, exciting na naman po ang topic natin, although maybe not as timely as today's topic. Next week, we'll be talking about abnormal uterine bleeding. So, medyo madugo ang ating topic, Dr. Raymond, pun intended. But before we conclude our program, again, reminding everyone to please answer our evaluation. And of course, thank you so much to both of our guests today on this episode of Health Updates for joining us and sharing your time with us. Maraming salamat po, Dr. Gia and Dr. Giselle.
Again, thank you so much. So you can still watch us on the playback at the TVUP
Yes,
YouTube channel and also at the TVUP Signal TV channel 101. So before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. You just go to www.youtube.com/TVUP-PH and you'll be able to see all in that live tab, all 225 webinars. It's being live streamed today, so it will be 226 after today's webinar. One of the tabs also is on shorts, so health update shorts po, no? So selected presentations that we feature in snippets found in the YouTube shorts tab po natin in the same TVUP YouTube channel. So if you have the time, and you don't want to watch the lengthy po, no, na episode, you'll be able to gain nuggets of wisdom in these very, very short videos po natin. Okay, so this formally closes our webinar for the week. Happy Valentine's Day po sa lahat.
Valentine's po.
And we look forward again to your company next Friday from 12 noon to 1 p.m. It's a date.
Yes, together we can stop preventable deaths.
So keep safe, keep healthy. See you online.
Bye po.
Bye-bye. Thank you.